All right, good morning, everybody. Welcome to the final grand rounds of 2019. We've had a nice season, I think, and the coming year is going to bring a lot more good talks and lectures. We're going to be off for the next 2 weeks, and then we'll start the decade off right with a talk about prostates. So don't miss that on the 7th. Today, we have Dr. Hunter joining us again. These are always one of my favorite talks. Dr. Hunter is the director of the Department of Medicine Hospitalist Program at OHSU. He's also the hospital-based Inpatient Medicine Services Director and the Associate Residency Program Director for the Department of Medicine. He has a special interest in adult inpatient medicine, and his roundups of the updates in hospital medicine are always thrilling. And Dr. Hunter did his MD at the University of Arkansas, his internship there as well, and then chief residency at OHSU. Dr. Hunter, thank you for joining us and welcome.
Can everyone hear me? I heard a rumor that the mics are variable, but well, let me know. So thank you very much for having me back. It is great to be back. I realized I keep a running update slide set, which I jettison debris and I add new things as they come, and I realized that this is from a summer talk, and what was I thinking? I should have changed this, but of course the coast. So disclosures, I don't know what I was thinking, but I foolishly signed up for 2 consecutive swing shifts, and I just did one last night, and I realized that was a little bit of a mistake. So if I start snoring, you just let me know, and I'll try to wake up. So same disclosures, I'm a generalist, so I'm not a specialist in anything as I go forward, and I don't really have any expertise, so we'll just go with that. My objectives are the same. So when you're rescued in about 50 minutes, be familiar with, the past year's top articles from my perspective that have a potential to change practice or not. Hopefully you can apply some of them to your daily work, and I like to provide a little bit of slide background to the subject matter, so little mini reviews we try to sneak in as we go forward. So my methods, Hunter, are the same. Again, I try to do some inpatient and outpatient relevant topics, so half or a third aren't asleep at any one time. I tend to try to focus on randomized trials more than reviews, more than observation or cohort studies, just because they have more potential to be impactful, but I violate that. And my sources and stuff are the same. I review the major literature that I can find, journal clubs, and synthesize reviews, and I steal things from tweets just to find articles as I go. Of course, I never try to talk about PE or venous thromboembolic disease, but it's impossible. So I lie to you just to start off the day. So we'll start off with a case. So a 50-something-year-old, not 60, professor is presenting some stale, old, maybe augmented by recent studies impacting hospital medicine since 2018 to a trapped audience. And the question is, does she talk about every article that he's read in the entire year? It's an option. Does one choose one paper to rule them all? This one I really struggled with, and I almost talked to you for an hour about umbilical cord clamping of maternal blood loss. So it's an option. I have it here. Pick a handful of highlights, 3-ish papers, and talk about them at length. I could give you a lecture on acid base for any of you who want to review. So I need you to just kind of reach for your phones, and we'll have a quick vote. Okay, that's good. Let's see what we got here. Wow. Well, I'm honored. Well, I'll talk about acid base. So thanks for coming. This is a great talk. Go for it. So I haven't spoken here since Richie Warnick died, and I remember him mocking the electronic answering machine with his artificial receiver, and so I always think of him here. I haven't been back since, so just a shout out to Richie. I miss him, and it's nice to be here. I wish I could make the clickers work, but I always push the wrong button, so I haven't. So no matter what you guys picked, I'm not going to talk about acid base. I will talk about 3 to 5 articles, plus or minus 10. So I have a few old, stale, moldy ones that occurred during this year, and then I have some fresh bread, which we'll talk about. And so first I'll just run through these. These occurred within the year, but it seems like they've been out forever. So I've decided I'm bored. I'm just going to tell you some highlights. So the first one was a New England Journal article paper, which came out first in the summer of last year as a kind of a pre-release and eventually released in January, February of this past year, looking at oral antibiotics for left-sided endocarditis. I think many of you have probably seen it. And just to tell you, in a very selected population with a low prevalence of MRSA, I think this one may have had 1%, who had good follow-up and who had, in fact, responded to therapy, they did well on well-chosen oral antibiotics. Really prompting a lot of consideration of, is this an option for select patients who, for whatever reason, cannot stay in the hospital or other for IV antibiotics, and I think it's an encouraging trial. The other was oral antibiotics for osteomyelitis. Came out, if not the same edition, soon thereafter, but it's twin, oral antibiotics for osteomyelitis. They looked at a population that was more representative of what we see, still a low percentage of resistant organisms, but a fair amount of patients with prosthetic devices and implants, so certainly relevant to what we might see. And again, a well-selected patient population with appropriate antibiotics, but these patients also did well on oral antibiotics, and I should say with both of these were following IV induction, so that it wasn't from the start. Cancer-associated thrombosis, I mean, I'm lying a little bit, so I'll just describe. There are two papers which are a little bit antique, this Hokusai and Selectee trial. They're looking at the role of DOACs in the setting of cancer-associated thrombosis. And I presented this last year, and there was an abstract which was catching the buzz of the heme community called this ATOM VTE. It is now published. So I'll just throw in there for real quickly some background. So cancer in clots happens. Historically, heparins were favored over warfarin or vitamin K antagonists. The evidence isn't awesome. We pretend it came out of the Bible not to be questioned, but it never really reached a level 1 or grade A evidence, but it is the standard recommendation. Obviously, one has to give shots, so the debate is, can one use direct oral agents? People have been doing it because it makes sense, but that's what these trials were looking at. So most of these were based on small subsets of other populations, 2%, 5% of the population, so not really large enough for us to draw conclusions, yet conclusions were drawn. And as I mentioned, I already presented the Hokusai and the Selectee. The concern with these is they certainly seem to work as well in cancer-associated blood clots, but they seem to be increased bleeding, especially in those patients who had GI malignancies. So that was a concern, and waiting on, and this ATOM VTE trial was the buzz because allegedly it didn't have it. So just a quick tangent, because this is always worth remembering. So in patients, this is from the last chest supplement. They're a little antique now in their updates, but the American College of Chest Physicians. They recommend for cancer-associated clots in patients for the first 3 months. Their first recommendation is a low molecular weight heparin or over vitamin K or warfarin, or the direct agents. And those are 2C, as you see there. For duration of therapy, for cancer-associated clots and people who don't have a high bleeding risk, they recommend really extended or no stop date or lifetime duration of therapy, and that's a grade 1B level of evidence, so better evidence actually than the choice of therapy. I bring this up because all these trials do not achieve that. All these trials use 6 months of therapy, which is a problem because it's not the standard duration. So I'm not going to run through these, but they're in the materials if you circulate them. I don't know if you do, but that's just a tabular summary of the Hokusai and Selectee. They all use 6 months of therapy. They all had at least the same clot rate and then some increased bleeding. And then I'll just show you a quick one-slider here on the ATOM VTE, which came out. That's an old slide, but lots of hype and hope based on that. And basically, this has just been accepted. It's not yet in press or pre-press, but Mayo Clinic. Open label trials, as they all were, randomized trial with cancer-associated clots. They, again, treated for 6 months. Their primary outcome was major bleeding, and then the secondary were clots and then a composite. And basically for major bleed, no difference. So again, the bleeding in the setting of GI malignancy was the subpopulation they were interested in, or everyone is, and there was no difference in bleeding. And then there was a secondary endpoint, a significant reduction in the recurrent clots. Probably wasn't powered for that, but at least as good in recurrent clots, and probably the same with bleeding. And then they did the composite endpoint, and so if you add in recurrent clots and major bleeding, it was the same event rate, whether you did a direct oral agent or whether it was a low molecular weight heparin product. This is just a quickie to show you, and not surprisingly, patients preferred, so yellow is they're happy. Patients preferred using the direct oral agent, which in this case was apixaban. They preferred that over the low molecular heparin product. In one case, only one favors dalteparin. So basically, Adams VTE really supports the prior trials, and I'm still bothered by the small number of GI cancers, all being open label, which you'll remember always seems to skew towards the open labelness, and then the non-guideline directed duration of therapy. Those are things which should concern us. Also, it's not for everybody, so a lot of drug-drug interactions to be cautious of, particularly those on cancer chemotherapy, which in this population is not trivial since these are cancer-associated clots, and those who are on a lot of GP450 and other hepatic enzyme medications. And the guidelines are not up to date yet, so they haven't incorporated these. So you might as well figure out how to saddle it, is the punchline. So my recommendation is mount up. I do think this makes sense. I do think it'd be nice to see probably some blinded trials, but it is certainly reasonable, and it is certainly happening. Patients are being treated with DOACs in the setting of cancer-associated clots, and I think it is reasonable. I think a discussion in patients with GI malignancies is wise, and I've had a handful now, and they will still opt, I have found, for the DOACs, at least of the small number I've chosen this route. So just watch for that, and I think finally some evidence to support what is really happening. This is, again, a quickie, a little moldy. Tsukuba, Chiral, Valsartan. So these are the angiotensin receptor and neprilysin inhibitors, the rage of now cardiology and heart failure. So I'm only talking about the inpatient application. I know there was an earlier trial on outpatient application. I presented the heart failure with reduced EF trial with acute decompensation, and there was no benefit in clinically meaningful endpoints in the hospital. So at that point, I did not endorse, and I still do not endorse, the use of this agent in the hospital for acute decompensated heart failure. To follow that up, there was another trial on heart failure with preserved ejection fraction that just came out. It just gets a one-slide reference real quickly. So again, the same ARNI, so angiotensin receptor neprilysin inhibitors in heart failure with preserved EF. I've already talked about the outpatient, but it's a randomized trial of an ARNI plus an ARB, 5,000 patients. And they had high BNP and had no change. So there's no change in meaningful outpoints, except hoping to push the reduction in BNP as a meaningful outcome. And I would argue that's a surrogate, which is not really quite appropriate for the inpatient use yet. So at this point, I don't see a use for inpatient ARNI inhibitors. I received a phone call from pharmacy or the pharmaceuticals after giving the grand rounds, wanting to know how I could draw that conclusion. So it was intriguing. So these are my discussions for the day. So now that we're done with the old stale moldy things. So everybody knows that. Buster, pain in my backside. Let's call the whole thing off. Getting high in the hospital. Something happens. Absence of evidence. Are we really doing this? And stop picking on me. So, and I forgot to add two. So in case you're worried, we wouldn't have enough to cover. Now, I'm not going to cover all these things, so like I said, I keep a running slide set, and I have my timer set to save you. So at 8:50 or 8:52, my alarm's going to go off, and I'm going to skip using these little icons to the summary, and sadly, leave the rest of them undiscussed. These are this year's cakes. My wife makes birthday cakes in themes for our girls, and this year my daughter is up at UW, and my other daughter is just starting pharmacy school at OSSU, so these are their cakes for this year. So when these appear, that's your exit and relief in case we seem like we're going long. So everybody knows that. So a 90-year-old man is admitted to the hospital for his 6th COPD flare in the past 3 months. Which of the following statements is true? There's a significant COPD underdiagnosis. There's a significant COPD over or misdiagnosis. Adding formal pulmonary function test guarantees a correct diagnosis of COPD. Asthma is COPD. You just kind of ruminate on that for a second and we'll move on. So COPD is actually common, as we know this, and it's the 3rd most common cause of mortality in the world. Readmissions are common, so 20% at 30 days, 45% at 5 years, and it's got a high mortality at 5 years. Not surprising because admission identifies a sick population. And we think we know COPD because we've seen it forever, or do we? So this is just a study looking at the prevalence of COPD. So as we go forward to the international validation trial of COPD, Sonia Bust up at OHSU, part of the BOLD and GOLD initiatives. So basically, their aim was to go through and measure the prevalence of COPD. This is a 2007 trial, so this is background. They looked at quality of life, limitations, respiratory symptoms. They ended up using surveys and pulmonary spirometry assessments in representative samples. I just show this for reference, just so we all remember that the diagnosis of COPD is post-bronchodilators, not pre. That's important because that is one of the biggest contributors to misdiagnosis. And we're not going to go through this flow sheet, but it exists for our diagnosis. And what they found was that the global estimate of COPD was about 10% of greater than stage 2 COPD, so not measuring stage 1. Some debate, is that really COPD? But 10%. They noticed that prior estimates estimated all stage 1 through stage 4 as 10%, of which most were stage 1. So they view this as a significant underestimate. They said 80% underestimate of COPD in the world. There's wide variation by country, by gender as we go forward. Representative in the United States is Lexington, Kentucky, which is interesting as the smoking capital of the US. But it may be not representative of every state that we see. So same comment, response rates were variable. So the lowest response rates were in the US, and the lowest cooperation rates with the trials were in the US, 14% response and 27% in Kentucky. So underdiagnosis, what caused it? So factors that affected underdiagnosis, maleness, being younger, never smoking, not really severe limitations, probably because in that population, maybe we're not thinking of checking it. The male sex, I'm not sure, so they're probably not being checked. Current smoking, lower education, and those are probably less access to being tested or physicians or healthcare. So that was what they found out. So COPD is underdiagnosed. That was their conclusion as we went forward. And then this came out this year. No, it's not. It's overdiagnosed. I don't know how many of you saw this, but so this is a same group. So this is, again, the gold or the bold group, which is going forward and continuing their population studies. Again, Sonia Bust and others. And they looked at diagnosed COPD and self-reported doctor diagnosis. So a doctor has diagnosed you with COPD and whether they use spirometry or not. And they found in this population, 62% of patients with a clinical diagnosis or doctor diagnosed had a false positive. Doctor diagnosed can still mean spirometry. And once you exclude asthma, they still had, of that population, a third were receiving ongoing respiratory therapy for those agents, so steroids and inhalers and other kind of therapies. I'm not going to spend a long time with this, but this is just a graphic representation of what they found. It varies by high and low middle income countries a little bit, so we tend to overdiagnose more in the high income, tend to underdiagnose more in the low income. Kentucky really right in the middle, so just a little representative sample. And whether or not one got PFTs, so it certainly wasn't the answer, but so you'll see, not surprisingly, with low access maybe to PFTs, fewer are getting them, so more clinical diagnosis. And then in the high-income countries, people are getting them and we're still misdiagnosing. So that's probably the point of make sure we're interpreting them correctly. I'm just going to fly through, and that's just the prevalence varies per high-income country. And then the overtreatment is well represented. So the United States is well ahead in the overtreatment. So just highlights, again, the importance of identifying the correct diagnosis before we apply therapies. So that's confusing a little bit. So COPD is underdiagnosed. That's probably related to suspicion. We don't have it, or access, testing, test interpretation as we go forward. Or COPD is overdiagnosed. Clinically, and not spirometry, or misinterpreting spirometry is probably what they felt as the most dominant reasons why it is overdiagnosed, resulting in both a missed opportunity to improve health in those who have COPD and we're not diagnosing, and then too many opportunities to put patients at risk. This is germane to hospitalists as we're screening, and clinic providers, as we're screening patients with diagnoses of COPD, making sure they have COPD. And maybe in the acute setting we're going to treat them, but before we sentence them to a lifelong bliss of episodic steroids, it's good to confirm. And those are really, clearly empiric treatments are appropriate, but plan to objectively confirm a COPD with post-bronchodilator spirometry. And that's just there again, but we'll skip that. So in this case, everybody's right. It's overdiagnosed, it's underdiagnosed. Adding PFTs, it doesn't guarantee the correct diagnosis, as I mentioned, because one has to interpret it correctly and make sure one is doing it post as well. And then asthmatic, some will debate this, but not really a COPD, different pathophys, more of an overlap, so which is how it gets called. Okay. Random, but I just love that picture because my wife and I love Mexican food, and so that seems like our brains sometimes. So I picked that. But so as you pick up the patient on hospital day 3, same patient, you notice medication reconciliation was not complete. That gave me great stress last night on my swing shift, the med reconciliation. Just very stressful. On review, he's taking metoprolol for hypertension. And you recall hearing somewhere that beta blockers worsen COPD, thus stop his metoprolol, improve mortality in COPD, so maintain his metoprolol, should be stopped for decompensated COPD, or they exist. Just ruminate on that. D is always correct, of course. But so this is the myth buster. So this is a myth. We've been here before. So I presented this myth a long time ago. The myth was beta blockers are contraindicated in COPD due to bronchoconstriction from competing with beta agonists. And I used my legend cynics, Pete Sullivan and Scott Sally. They maintain their cynical traits to this day, so they're still wonderful mythbusters. Went over this trial, which was a look at beta blockers may reduce mortality, blah, blah, blah. This was a cohort trial. So again, one of the risks being a lot of potential for bias and confounding, so we have to be careful drawing conclusions. But it was impressive. It was done in UTRACT. Every GP enters every visit into the database, so there's a lot of data to be analyzed. They looked at patients more than 45 with COPD. They had a 70% accuracy, so a little referent to the prior diagnosis issues. And they looked at all-cause mortality and exacerbations. And I won't go through this at length, but better than buttered fresh bread. If you looked at this, reduced really outcomes for everything. So just mortality and exacerbations, whether you had coronary disease, whether you had more than 2 pulmonary drugs, whether you had beta agonists as well, whether you use inhaled anticholinergics, whether you had new COPD or not, whether you were severe enough to go to a pulmonologist, it seemed to improve mortality. So it seemed to bust the myth. So this myth is busted. That was our conclusion. Still needed a prospective trial, but it sure seemed reasonable in a population to use it. So shouldn't be afraid to use. So am I asked, and it shall be given, seek and ye shall find. So 9 years later, we have a randomized trial. This just came out. I guess it's a month plus ago now. The BLOCK COPD trial, metoprolol to prevent acute exacerbations of COPD. And they basically looked at clinical COPD and a confirmed diagnosis, and so post-bronchodilator PFTs, and at risk, so high-risk patients, meaning they had exacerbations before, they were already on oxygen, they had taken antibiotics, they had been to the ER or hospitalized. So these are patients who have proven they have a predilection to be admitted. They took 500 of these patients, and they, with a gold diagnosed COPD, they randomized them to metoprolol 50 milligrams a day and placebo. They matched their cohorts. And the outcomes basically was a time to the first exacerbation. I don't think I'll run through that completely, but really more than 2 of the classic kind of signs and resulting in steroids. Numerous secondary outcomes, which I won't go through at length, but all make sense. The rate of exacerbation, mortality, hospitalization, walk, et cetera. They planned about a year trial, and then they terminated it for safety at 6 months, just based on the interim analysis. So that's what's been published. And basically, there was no change in the time to the exacerbation. So whether you were on placebo or metoprolol, did fine, so that's reassuring. But it was interesting, but the time to the first moderate, severe, or severe exacerbation, it was more likely to occur in patients who were getting metoprolol. And so, and then the probability of I think I said that. This then is the rate. So not only is the time to severe, but the rate to severe is also higher. So you're more likely to have it faster with severe, very severe as you go forward. So that's a little confusing again. They also looked at the respiratory events. So with respect to safety, there was a low event rate. There tended to be more total events in the beta blocker arm and 3 times more exacerbations in the placebo arm as you go forward. And that's a secondary event. And there was a non-significant, twice the mortality in the beta blocker arm. Again, not really powered for this, but just worth noting, but it is not trivial. So basically, this trial showed no increase in the time to the first exacerbation. The way I interpret this is, but if you're going to have one, it's going to be worse, is the way I interpret that, because the time to is the same, but the likelihood of severity is more. So it did not confirm in a randomized trial that event reduction with beta blockers is seen in the prior observational trials across all populations. This trial excluded patients already on beta blockers. So the old trial did not. So it may be that those that need beta blockers in whom the benefit really exists weren't in this trial, but patients who didn't seem to need beta blockers seem to be at increased risk for bad outcomes. So event rates were small, but perhaps for those not needing beta blockers, one could consider alternatives for whatever your diagnosis is. For those needing beta blockers, monitor closely, but that is the subset of the population that may benefit, whether it's heart failure, whether it's coronary disease, and we, I guess, don't know the answer still because it's based on cohort-level data and observational trials. So for the answer is, what does it do? Well, it probably, or it could worsen COPD. The stop is metoprolol. I've suggested that that may not be true if they have a coronary disease. They, of course, exist. And, yeah, of course, that has not been studied, stopping and decompensated COPD. That was more a statement referent to heart failure. So this myth is busted. So it proves, in fact, this is why we need RCTs. All the well-designed observational cohort trials and retrospectives can definitely change our thinking, but they are not. They should be hypothesis generating as we go forward. Okay, we don't need the exit sign yet, but 49-year-old man, active IV drug use or injection drug use, admitted with fever, dyspnea, hand and back pain, was found to have endocarditis. What is the likelihood that his back pain is pathologic and needs to be explored? So imaged or other, but imaged. Low, high, unknown. Doesn't really matter because we're going to treat the same. You can think about those 4. So there's a pain in my backside. So this is an emergency department population, not quite inpatient population, but has relevance, obviously, because those folks can get admitted. And they, obviously, it's common. So evaluating back pain is common in primary care, but also to hospital-based clinicians. Guidelines suggest further evaluation with suspected cancer, injection drug use, steroid immunosuppression, suspected spinal arthropathy, major trauma, or in some trials, the absence of trauma and unexplained back pain and non-thoracic distribution. Many of these flags have been studied in primary care, but not hospital-based medicine. So this was a trial done in emergency medicine. It's a systematic review of trials evaluating the prevalence of spinal pathology or diagnostic accuracy of red flags in adults who present to the emergency department with lower back pain. And so the aim is obviously to identify patients who need further workup. There is an existing prevalence of about a 1% in the primary care population of pathology needing further workup, and not really known in the inpatient referral bias or admission bias population. There's numerous guidelines out there. There's a lot of red flags. To go through, and they look to summarize those and see if they can identify which were the best. They report their data in likelihood ratios, and so really the ability of a test to change your pre-test probability to your post-test probability affecting will you treat or not treat, will you test or not treat, based on just how much it affects your likelihood. I won't go through it at length. All I'll do is say that the numbers, which are derived from sensitivity and specificity, are kind of above 10 is really good, so it has a great potential to change your pre-test. Below 0.1 is really good as a likelihood to change pretest in a kind of a lower likelihood. In the middle, it varies. So their methods are well described. It's a well-done trial. They incorporated 22 trials, whittled from 1,300. They found the prevalence to be higher, not surprising in the inpatient or in the ED. So 2.5 to 5% is what they found in their trial. They found that the absence of flags was not reliable to rule out pathology. I think we know that, but it's interesting to see some numbers applied to that. There were a few exceptions. So they looked at historical features, and they looked at clinical features. And here is for any spinal pathology, not a specific spinal pathology. They found that new urinary retention was pretty good to change likelihood ratios, and being on oral coagulation, anticoagulants, was pretty good. With clinical features, they found that really good was a bladder suprapubic fulness. So obviously, if one has a neurogenic bladder, that's bad. Hemoglobin was really low, and then hemoglobin that was low were very good. Saddle anesthesia was also good. So they found those with any pathology were very good likelihood ratios. They found really no reliable likelihood ratio negatives. So the absence of any of those didn't help. But the presence of was helpful. With respect to specific pathologies, so again, the populations we see, so epidural abscess. So the history of injection drug use, very good likelihood ratio. The history of having indwelling vascular access, again, a very good likelihood ratio. Things that don't surprise us, but again, putting numbers to what we think about. And these are really pretty good, not quite as high, but history of fracture and the combination of spine pain, fever, and some neurodeficit and having low blood pressure. Absence of these meant nothing, so they weren't able to rule out anything. Cord compression, nothing good as we go forward, so couldn't rule that out. And I think I misread here a second, but vertebral trauma, so trauma and an abnormal exam, very good. And actually, the likelihood ratio is very good here. So if you've had no history of trauma, that was very useful. I'll go back because I misread this. No risk factors makes epidural abscess unlikely, and no inflammation and risk factors as well. So I misinterpreted that for you. And then for cancer, a history or suspicion of cancer, kind of like the DAO and other articles have always suggested, a very good likelihood ratio. So and as we go forward, and lack of any history or suspicion of cancer makes a cancer diagnosis less likely. Abnormal neuro exam is good, not awesome, but definitely if you have an abnormal exam, it's going to suggest a need to pursue. And then severe spinal stenosis, really obesity, only thing that they found, and that's a fair likelihood ratio, but not awesome, and certainly not a likelihood ratio negative, so you can't rule it out. So in our patient population, a 49-year-old injection drug use, what's the likelihood is back pain is pathologic, needs to be explored. You know, high, actually, in an injection drug user with fever and back pain. So obviously, I think we would image them, but like I said, it gives numbers. I don't think this is true, but some would argue that you're going to treat with antibiotics, but you probably want to know if there's some drainable focus in there. So the prevalence of spinal pathology for patients in back pain was higher, 2 to 5%, or 2 to 5 times than primary care. Most red flags had neither the adequate characteristics to rule in or rule out diagnoses. These were the most powerful ones that I ran through. I won't run through them again, but it's trauma, it's cancer history, et cetera. And we don't know the prevalence in the hospitalized patient. It's probably a little higher, obviously, because they get through the funnel of the ED and they get admitted, so just be aware of that when you're admitting patients to the hospital. Okay, I was going to sing this one, but I never master the intro, so I won't. You are coordinating an upcoming CME conference and come across an article that will likely appeal to one of your faculty known to focus on cost-conscious care. You decide to send the article to him and to use in a talk, bury it, save it for your own personal stash, and never share it until you give it. Send it and present it yourself or invest in esomeprazole. So let's call the whole thing off. So I think I could sing this. I could sing you say either, you say either as we go forward, but this sets the stage. So we all know about life cycles. So although I tell you I know that I went and was exposed to life cycles once, I have to say I don't remember the Tinium solium, the malaria, the hookworm as well, schistosomiasis, or leptospira. I don't remember them well, but I know they exist. There also are life cycles of the drugs and medication devices. So this is kind of intriguing. It goes through the preclinical phase, the clinical phase, patent and registration. It gets into a larger use of phase 4 trials, and all the way through to growth, maturity, then the decline. You'll notice that the orange is kind of the pharma investment. Obviously varies per drug, per whatever, but there's an early investment phase. And then there's the later reaping of the harvest, which is the green. Late in the course, the dotted line represents when new competition comes up, and then we see, of course, a decline in the revenue phase, and that's a problem for people. So this is kind of a strategy, which many of you I'm sure are aware of, is chiral switching, or changing one added ligand to the structure, making it a new drug. You can repatent it, and that's chiral switching is a well-known strategy of converting a racemic drug, so two kind of a symmetric constructs, taking off one of the ligands, so you have a single enantiomer, and that's what they talk about, levro, dextro, whatever, and that's a strategy which can repatent. And by doing that, you can push out the profit curve. And so that's a well-known strategy in marketing, not just with drugs, but with devices, little tweaks on devices as we go forward. It is debatable whether these new drugs are better or not. I'm not going to really dive into that, although for many of them, there's not a lot of great evidence that the newer formulations are that good. They are more expensive as we go forward. So this is a brief article that came out. I just thought it was really interesting. It was a brief observation report in the Annals looking at Medicare spending on single enantiomer drugs versus their racemic, so the blend of the structures precursors. So, again, they look to estimate the potential savings to Medicare using, if they stuck with the precursor racemic, instead of using the single enantiomer version. They used the drugs at the FDA database. They searched for prefix names, excuse me, to determine spending. And this was the most recent data sets available for Medicare spending and then beneficiary out-of-pocket spending. So the dates are not quite in sync, but it's the most recent data. They used Medicare Part D data. And they ended up identifying 12 most common single enantiomer drugs that the FDA had approved based on racemic precursors and that they had data for. So they didn't have data for all of them. So these are them, and so not surprising, I'll run through the levofloxacin, ofloxacin, levobuterol, albuterol, esomeprazole, omeprazole. It goes on and on as we go forward. Levo, leucovorin, dexlansoprazole, lansoprazole. Lots of additions and twists. You can see where the either comes in a second. I'll focus on these the most. These were the biggest hitters. So esomeprazole, so PPIs, and then citalopram. So I won't have you read line by line, but this is the tabular table from there, which is Medicare spending and potential savings. If they made a complete one-to-one substitution for the original racemic instead of the single enantiomer drug, then they had a big table on beneficiary spending of single enantiomer drugs, so what's out of pocket. And this is basically what they showed. So this is mostly in billions. So they showed that the potential Medicare spending for like, and I'll just go through the highlighters here, but even though 0.5 billion isn't trivial, just for esomeprazole, omeprazole, $13 billion potentially saved. For dexlansoprazole, lansoprazole, $2.4 billion saved. And citalopram, escitalopram, $2.2 billion saved. When they look at beneficiary spending, I guess this is just spending, I lied, but little less magnitude, but 98 million, 140 million, 92 million, so a fair amount of spending being done for enantiomer versus racemic drugs, and here is the net racemic savings. So just on the esomeprazole, the dexlansoprazole, and the citalopram, it's a total of about $16 billion during that time frame of spending. This is just a graphic representation of the same, so I'm not going to go through it again that much, but these are billions of dollars, so it's just intriguing. These are just looking at PPIs alone. It's about $15 billion over that time frame. So there are numerous caveats and limitations to the trial. So obviously it limits it to the 7- and 5-year review periods. Thus, the actual magnitude over time could be much larger. They clearly didn't identify all medications. They probably identified the big ones. So there's probably potentially more cost there. They didn't include Medicare Advantage plans. Yes, they didn't have it in the data set, so that's going to change values. They have modeled their assumption on complete substitution. So that's probably not real, but so they didn't factor in other factors, maybe some scenarios where the other drug is better tolerated, but so they assumed that. And there are numerous other things influencing these things. So beneficiary income status and Part D plan affects how you'll qualify. So the take home is newer isn't necessarily better. I didn't show you the data on that, but probably the most recent and referent trial is the esomeprazole trial, which shows no difference except in cost as we go forward. Significant potential savings, favoring a racemic precursor medications. Hospital and group formularies could default to racemic precursors unless the evidence to support it. This is probably where the marketing impact on P&T, pharmacy and therapeutic committees is most important for us because it impacts what we prescribe. And just be cognizant. So this is more of a sit, meditate and reflect, because if there's an opportunity to choose an agent which is a racemic or precursor that doesn't have a new one with better data, stick with the precursor. I think it makes sense. So I decided to send it to him. He presented at our conference, and then I saved it and presented it myself. So, and invested in esomeprazole. Think about it. So we can go through, and again, I was practicing singing it, but I never got the tune down this weekend. So anyway, new banh mi recipe we found. It's a killer. We're having a good time with that. So there's a little add-on I forgot to put in the list because my list was so long. I do not like green eggs and ham. Sam, I am. So I love this book, and I'm sorry my kids are old enough so I can't read it to them anymore, but it's Procalcitonin by Dr. Seuss. I am Sam. Sam, I am. And I do not like Sam, I am. I think I took out the wrong thing because I'm not going to talk about Procalcitonin. Let's see what I do here. So here's a case. So yeah, okay, we debate rages on for Procalcitonin. I still believe there's a role, although there are numerous trials which have come out questioning that role. But but I think it's likely its best role is to reduce antibiotic exposure, which is why it exists, in patients with undifferentiated respiratory symptoms and shortening the duration in known confirmed lower respiratory tract infections. We should be doing that anyway, so one can wonder if you need it, but that's probably the best role. Numerous trials have looked at in the setting of pneumonia, does it help with diagnosis, and I think not as impressive, but it's good to differentiate, but we're not going to talk about that today. There's a new kid on the block, so CRP, could you, would you with CRP? So this is not a new concept. In 2010, there's a trial looking at antibiotics in addition to steroids for acute exacerbations of COPD. They looked at 200 patients with COPD exacerbations. They looked at clinical success and numerous secondary outcomes, of which one of them was CRP levels. And basically, they noticed in their trial that those who had CRPs that were markedly elevated, if they were treated with antibiotics, they tended to do better. And flip side, it didn't seem to have any benefit if their CRP was not elevated more than 50. So they noticed that that's a background. On that background, there are a couple trials that came out in 2019 looking at CRP-guided antibiotic treatment in acute exacerbations of COPD and hospital admissions. One in the European Respiratory Journal, one in the New England Journal, all relatively recent. The European trial, building on that former trial, they did an open-label randomized trial of CRP-directed or GOLD-directed therapy, so usual care. They had 200 patients randomized equally. In the CRP arm, they basically, if their CRP was elevated, they treated with amoxiclav for 7 days, no antibiotics if it was not elevated. If you had no antibiotics, they rechecked the CRP in 24 hours. If it was elevated, they treated for 7 days, and likewise, if it was not elevated, they did not treat. Goal-directed, it's what we think about typically. It's sputum purulence, it's dyspnea, it's sputum volume, kind of the classic things. We think about treating COPD exacerbations. If they had those, they were treated with amox, and if they did not, they received no antibiotics. What were the outcomes? So outcomes basically in the antibiotics within 24 hours, basically a marked reduction, so 15% reduction of receiving antibiotics in 24 hours in the CRP arm. No difference in failure rates, so 30-day failure, length of stay, time to next exacerbation, quality of life. So less antibiotic exposure, no apparent difference in clinical outcomes. The New England Journal paper is a clinic population, so a pragmatic, it's open label, randomized trial in England, different resistance patterns, but they used point of care, CRP guided versus usual care management. Similar, age more than 40 with exacerbations. And I no longer remember why I wrote 33% there, but they randomized them to CRP or usual care. And basically, CRP is less than 20. They made recommendations that antibiotics are unlikely helpful and usually not prescribed. And if it's more than 20, they're likely helpful and should be prescribed. The primary outcome was patient-reported antibiotic use and COPD-related health status. Maybe not the hardest of outcomes, but of note. They looked at 1 to 2 week phone follow-ups, 4-week visits, and then 6 months they did a questionnaire to see what happened. And basically, they looked at the dyspnea and sputum purulence score. And so for the predicted probability of use of antibiotics, so this is just a usual care versus CRP. So the CRP, if you ended up having more than one Anthonian criteria, and those are those criteria, it reduced the likelihood of exposure. So it's basically showing the same thing. By using CRP-guided therapy, you're less likely to receive antibiotics if you're higher than your cutoff. And so what to do with that? Oh, I do still like procalcitonin and CRP. Thank you, Sam, I am. So it's encouraging efforts to employ a readily available test. Unlike PCT, which I think you all run more rapidly here, and our VA has finally run it after years of wondering, gee, should we run it? The university still does not run it for us as well, so we don't have that as an effort to decrease antibiotic use. This hospital-based study noted that prescribing antibiotics, if the CRP was less than 50, reduced prescribing by 14%, so every 6 exacerbations with no change in clinical outcomes. Again, the studies were small, groups weren't well matched. The clinic-based study, it's well done, provocative, suggesting not prescribing antibiotics for COPD exacerbations with CRP less than 20 could decrease prescribing by 20%, and nobody needed to treat at 5. You notice the CRPs are different levels, so how do we factor that in? But they're encouraging. Both trials are open label. It's still preliminary, but I think look for more trials on CRP, similar to efforts with procalcitonin to reduce antibiotic prescribing. And it certainly is simpler if it could be binary as less than or more than. So just keep your eyes out for that trial. Antique, found it in some closet, decided to share that picture with you. Case, okay, so during an otherwise relaxing on-call night, you're paged by a nurse asking to see and maybe provide treatment for a 75-year-old woman, poorly controlled hypertension, with cellulitis. Blood pressure is 190/96 on her evening vitals. You find she doesn't have any symptoms, she's really doing fine, and she's not very happy that you woke her up. You transfer to the ICU for nitroprusside, you administer labetalol, you administer hydralazine, you treat her pain and review her medications and blood pressure trends, see if she might benefit from blood pressure med adjustment. You can guess what that answer is. So getting high in the hospital. So this is a review article, which obviously I'll just reference you to it. It was a very timely recent review article on acute severe hypertension, which is germane to clinic-based and inpatient population, so it's a great review to go through. This is just a curve showing how the chronic hypertension shifts in autoregulation such that folks with chronic hypertension tolerate higher pressures better and perfusion pressures, but yet they are at risk as you shift them, is what this is showing. And I won't spend a lot of time with that one. They have this flow sheet here, which is a nice flow sheet of elevated blood pressures with or without symptoms or signs. I simplified it or confused it with color. You decide. But basically, there's urgency, emergency, and coincident is how I kind of phrased it. So urgency, there's vague symptoms, there are atypical symptoms, some headaches, some atypical chest pain, dizziness. And those patients, according to this review, should be treated with rapid oral agents, adjusting chronic medications, discharge them when their blood pressure is less than 180 to 110. They should be followed up to see how their blood pressure is doing. And there's no clear evidence that their short-term outcomes are worse or better by leaving their blood pressure the same or treating, but if for long-term it makes sense. Emergency, and this is what we think about, malignant hypertension, hypertensive encephalopathy, those two could be merged. Green from hemorrhage, stroke, ACS, heart failure, dissection. These patients should probably be in the ICU. They should be receiving IV meds and their various medicines for different targets. And coincident, like our patient, there's another diagnosis which is driving this, and they're having hypertension. Probably just adjusting the meds, maybe, and following up in 7 days. Do we actually worsen outcomes is the question. So this is just, I redid a flow sheet for me to use when I'm in the hospital, so you don't have to study this. But this is just from their flow sheet on different diagnoses, different targets, and different goals of therapy, different agents to use. So again, the point here is not to go through this, but again, if it's available for reference, and it's in the article. So that's a resource as well. These are the medications that they recommend. So again, I'm not going to go through those. 2 trials came out this year. One is reducing unnecessary treatment of asymptomatic blood pressures in gen med wards. One is the clinical outcomes after intensifying antihypertensive meds on older adults at hospital discharge. So I didn't realize this was Zach Jacobs, one of our own. He was a hospitalist fellow down at UCSF and did a quality project looking at manipulating the electronic health record and education to basically look at changing prescribing patterns for use of IV blood pressure medications in hospital medicine population. They used 160/90 as their threshold as they look forward. So they had a 2-tiered intervention. They had the education campaign, the no IV for high BP was their campaign. And then they liberalized the electronic health record notification parameters. So it used to be 160, they changed it to 180. And that was really it. They gave guidelines on agents to use, not to use. And they basically showed at baseline, 11% of these patients were already receiving IV hydralazine or labetalol. After the intervention, 7%, not a huge reduction. But they showed they could reduce the prescribing of IV agents in the hospital. No differences in outcomes in that population. This is another trial which is relevant as well. This is a clinical outcomes after intensifying antihypertensive med regimens among older adults at the hospital discharge. Just a quickie. So this is a retrospective cohort trial, propensity matched, which I'm not going to, I include the methodology here in a second, but I'm not going to go through it at length. Veterans hospitalized for non-cardiac conditions with transient elevations in BP during the hospital. And what they found was adjusting the antihypertensive regimen increased the odds of 30-day readmission by about 20%, of serious adverse events about 40%, And it didn't seem to change, although there was a trend, but didn't seem to change 1-year cardiovascular events, and there was no change in blood pressure over time. So this is hypothesis generating, but it's prudent to not change blood pressure agents unless needed. So obviously judgment is required, and clearly if you have patients who have symptoms or you're concerned, it's very high, it's reasonable. But probably the most important is be in touch with a primary care doc just to make sure we're all on the same page. Again, this is a retrospective trial, so it is hypothesis generating. The propensity matching, in theory, is normalizing the cohort to be more like a randomized trial. They're cheaper than randomized trials, so we're going to be seeing more and more and more propensity match trials where they match a population first, and then they kind of look at what they were treated with. So the hypertension lowdown is hypertension happens. Systems can be implemented to reduce prescribing and asymptomatic in-hospital blood pressure elevations. I think they probably could have done more, but they just changed the parameters is all they did. So do use IV agents for hypertensive emergencies. Do use oral agents for patients with symptomatic hypertensive urgencies, so not the alarm. Think twice before adding or adapting blood pressure meds in patients with asymptomatic blood pressure elevations. And probably don't use IV agents for asymptomatic inpatient hypertension. Again, we see that, and still 1 in 10 of our patients is getting them. And just assure we're notifying PCP, because this is a big issue with our blood pressure changes. So I know the alarm's going to go off in a second, but I'm going to plow through this one for fun. So this happens. So fecal transplants, they're everywhere. They're too good to be true. They're awesome. Best thing since buttered bread, although it's hard to imagine poop is best thing since buttered bread. But they report a really high success rate in patients with a recurrent C. difficile-associated diarrhea. 80 to 90%. That may require second transplant, but a very high success rate in a population that has already failed. So that's impressive. This is a nice review. I think I meant to delete this slide, but it's a nice review, which is just the nuts and bolts of fecal microbiota transplantation. There's an interesting history. The first was back in the 50s. It's commonly used for recurrent C. diff. There's a systematic review in 2017. They looked at 37 trials, of which 7 were randomized trials. Fecal transplants were better than VANC. 90% had an over-response rate with requiring 2 doses, but 84% response rate with a single transplant. Colonoscopy, the rate was a little higher, upper GI a little lower. There's no difference fresh versus frozen pill or pill form. Screening processes were consistent, but the preparation varied, and there were rare side effects. So what could go wrong? It just sounds awesome in every way, and I'm sure many of you may have seen. So this is a systematic review of the safety. And so the adverse events in this systematic review were minor, but bloating, belching, cramps, pain and discomfort, nausea, vomiting, not surprising, some transient fever, UTIs, diarrhea, and some bowel irregularity. Serious adverse events, there were, in their review, no aspiration via upper GI, 1 mucosal tear, just from technique, 50 deaths, did not feel it was attributable to the transplant, but that's what the systematic review identified for safety of it. If you look at clinicaltrials.gov, there's numerous trials going on now for other uses of fecal transplants, whether it's a bone marrow transplant to reduce GVHD, inflammatory bowel disease, hepatic encephalopathy, IBS, functional constipation, decolonization of multi-resistant drugs, severe pancreatitis, anorexia nervosa. That's interesting. Impact on HIV immunology. So there's a lot of trials. So this one I stumbled across because I constantly surf the cycling websites, but is poop the next doping frontier? So this is they're looking at stool microbiota profiles in elite athletes, and then looking to see if that profile can be given to athletes and they can become elite athletes. And so for those of you who feel like you're under-trained and not performing, consider this. So, I highlight this more because this article just came out. So drug-resistant E. coli bacteremia transmitted by a fecal transplant. So this headline, of course, is terrifying, and my God, it's killing us. And so just to go through, they report 2 cases. Again, for speed, I'll just go through. One is a cirrhotic. He's in a trial for hepatic encephalopathy. So he's getting his transplant for hepatic encephalopathy. He received capsules, and he ended up getting a bacteremia sepsis from ESBL producing E. coli. He was treated and did well. Second case, a 70-year-old. He's got MDS. He's had a bone marrow transplant with a conditioning regimen. He's on fecal transplant for his GVHD reduction clinical trial. Ends up getting a transplant, gets fever chills, blood cultures, ends up getting E. coli resistance. They're later confirmed that both patients received the transplant from the same donor. They then looked at the other donor, other recipients to see if there are any results. And I go through pretty quickly now just because I don't want to belabor. So they confirmed the transmission from the first case, that it was from the same source. So is this a requiem for what sounded too good to be true for a fecal transplant? So this was another recent review. So the incidence of bloodstream infection and length of hospital stay and survival in patients with recurrent C. diff with its new genus name, Clostridioides, for fecal transplant. This was a single-center prospective cohort trial, all recurrent C. diff patients, whether it's fecal transplant versus antibiotics, again, matched on a propensity score. So they identify a monster cohort. They look at all the confounders they could have. They then sort them kind of by their similar confounders. And then in those groups, they look who got the transplant and who got the antibiotics, and that's how they propensity score. So it is a retrospective, but in theory, pretty well matched, and they look at that subset, and that's how they pick the population. 90-day bloodstream infections, what they looked at, and survival. And basically, in their review, in this trial, so yes, bloodstream infections are happening. So in the, well, I guess, I didn't choose it for this reason, but in Finney and Coates, and then Osler's first description of C. difficile, well, not C. difficile, pseudomembranous colitis, they described a chartreuse fluorescence of the stool. That green, I've decided, is chartreuse. I did not choose it for that reason, but so perfectly appropriate. But fecal transplant, there were 5% bloodstream infections, and the antibiotic group had 20%. After they propensity matched them, a similar reference. So still, yes, people are getting bacteremia from fecal transplants. It sure doesn't look worse than antibiotics, though, so from their trial. When they look at secondary outcomes, really showing the same. So length of stay is less with the fecal transplants. Survival is less. These are secondary outcomes, but and mortality is less. So the authors say maybe the fecal transplant is actually decreasing bloodstream infections by better C. diff management. C. diff is known to damage the gut barrier. Maybe that is where these organisms are coming from. So if they have less inflammation, if they have less exposure, vancomycin is known to increase risk. So that's their theory. Otherwise, it's restoring healthy microbiota, which could decrease the gut resistosome, therefore reducing the risk of bloodstream infections that are resistant. And the trial was limited mostly to vancomycin, not fidaxomicin. I'm just going to fly through this one because we're at time. They did the same, a very different trial looking at the impact in immunocompromised hosts. And basically, they found no difference. So they found that they all met criteria. And I'm not going to go through this. They did see a very small percentage of patients with infections, but they looked like it was still safe in that thing. So bloodstream infections are happening. They seem to be happening less with the fecal transplants than with standard therapy. They are probably safe to use in immunocompromised patients. It really confirms prior data, so full steam ahead. I think we still need to be safe, make sure the protocols are followed, and then one recommendation is consider screening for MDROs. So with that, I'm going to quickly skip through now to my summary. So what I did talk about, and I'm not going to re-summarize the stale moldy bread as we go forward, but so be suspicious and objective in the diagnosis of COPD. One, we want to make sure we're identifying patients with the disease so we can get the right therapy. Two, we want to make sure we're identifying patients without the disease so they don't get the wrong therapy. So work on that. The myth buster. So maybe beta blockers aren't the elixir of life. In patients not needing beta blockers, they may cause harm in the setting of acute exacerbations of COPD, and we should look for alternatives. We don't know the answer in patients who need beta blockers, like heart failure and coronary disease active. And it's probably still reasonable to use them based on prior observational data. Pain in my backside. So pathologic back pain is more common in the emergency department than primary care clinics. Many red flags aren't overly useful. Some are, and I left those for you. I didn't discuss this, the kibosh for K-exhalate. So you may have seen a trial which came out this year, but not new, just highlighting the bowel ischemia and necrosis from using K-exhalate in the setting of hyperkalemia. It's certainly not epidemic. It probably is at twice the increased risk compared to control populations or matched populations. The risk is probably about 0.1%. So not huge. It's probably double the risk of not receiving it. Probably more importantly is, does Kexlate actually work? It probably only reduces potassium about a milliequivalent over time, and that's probably not as much, and it's chronic. So realistically, this, and even the new Petromir doesn't reduce it that much either, so it's probably the end of the time. Let's call the whole thing off. So that's the reference, obviously, to antitumors. So for now, stick with the classics. You may be forced to use a new agent, obviously, but just be thoughtful. Getting high in the hospital, so use less IV blood pressure meds in the hospital. Caution, changing meds, and then call your PCP if you do. So this happens. Fecal transplant is still better than standard treatment in recurrent C. difficile, but yes, you may see resistant infections. Green eggs and ham, so CRP may be coming, but treat pneumonia, and I don't do this much, for 5 days. Now, there's reasons you can go past that if they're sicker and they're not doing well, but shoot for a much shorter course as we go forward. So I didn't talk about the absence of evidence, but the sodium restriction and heart failure, you may have seen that paper. I think it came out a year ago, so it's just lapsing past the year. So basically, of all the randomized trials looking at salt restriction and congestive heart failure, of which they were poorly done, or a lot of heterogeneity, well, not poorly done, but a lot of heterogeneity and various quality, there's no evidence that it really helps. So we don't really have good evidence that salt restriction helps, and we probably shouldn't be pushing for it that hard. Giving iron, so I do think it's reasonable to give iron to patients with iron deficiency and heart failure. And if you have the slide set, there's a couple trials came out that looked at this. They use a different definition of iron deficiency, so that's probably the only thing to think about. If your ferritins are elevated, or if your saturation is elevated, you can use a higher ferritin. Stop picking on me. These are just trials looking at uses of PICs. So we are overusing PICs, or PICs are being placed in a high number of patients who probably shouldn't be getting PICs, particularly renal failure patients. So just be very cognizant of who we place them in. Strive for single lumen more than double lumen PICs, and an EHR intervention can help that. So that's my talk. I think I'm 1 minute past. It's a little bit psycho, but Merry Christmas. Merry Christmas. Yeah, I can stay for, I know we're over, so. Yeah.
The people who were treated for hypertension, what were those serious adverse effects that
Yeah, so no mortality. So the question was in patients who were discharged, this is the hypertension, ingesting medications on patients with hypertension in the hospital, what were the adverse effects people experienced in those that adjusted? Mostly it was changes in renal insufficiency, getting readmitted to the hospital, getting seen in clinic, things of that. Not hard outcomes like death, mortality, MIs. It wasn't hard outcomes, but it was probably more healthcare visits and costs.
Could you clarify briefly when it's appropriate to use oral antibiotics in osteomyelitis, especially when there has been things like total joints? Because I think the standard ligaments, those things need to be drained from some kind of fluid. It's a big deal. So just to clarify that.
Yeah, so you'll be out of my scope soon. So the concept of so acute versus chronic management of osteomyelitis. This trial I referenced obviously was more focused on the acute initial management and then sustained management for the duration of therapy. All of them received initial IV therapy, then they received oral therapy as they went out to the hospital. So I know that's not quite your question, but that's what that trial was looking at. And those patients, again, it was a nice mix of patients with hardware, without hardware, who ended up having hardware removed, which was probably the majority of patients who had hardware, but not all. And then of those patients who'd had surgery and had antibiotics after, they did just as well. And this is where, and I'm not an expert at the long-term management of then when you switch to an oral antibiotic in the setting of osteomyelitis, but my assumption is the standard of therapy probably has been IV antibiotics for a course of time, i.e. 6 weeks-ish, adjusted usually in clinic on how people are doing. Probably after that initial phase, transitioning to oral agents based on therapy. Although after 6 weeks, it might be fine. Dave, you, of course, are my regional expert sitting right there, so you probably could answer the long-term transition to oral better than I could. But.
Well,
so many variables, and there's always the futility question. So the desired use or the attraction to the oral conversion are in patients that are, because of their underlying comorbidities, are going to be in chronic suppression for life, and they can't handle a PIC for life.
Okay. Okay. Well, I know we're over time. I don't see any waving or people throwing things. So thank you very much, and thank you. So do you share those?